So on Blackboard too, I'm gonna pull this up in just a second, but make for sure you review the energy systems, and then when we do the aerobic, anaerobic, it'll make a lot more sense too. So at the very beginning of those, if you got those finished or not, I don't know if you saw my email for that.
Yeah, the videos.
Yeah.
Yeah.
Okay, good. And
Which we watched it last week, so I think they were posted on last week's and this week's.
yes, they were.
So.
Yeah, that's why I was like, I was trying to so they were both.
Yeah.
Is what I was trying to do. So that way you wouldn't have to hunt for it.
I know, it's like, man.
And then I feel like you're so far away. But it's okay. We're going to it'll be fine. I am going to go ahead and, I am recording. And so I am going to share. We're going to do the electrical activity of the heart, part 1. It says ECG, module 1. I think it says module 1. Oh, no. This one? Okay. And I'm going to share my screen. This one. Sweet. Okay. All right. So, sure. Okay, good. All right. I believe it's recording. So we're going to talk about for each one of these two of how to read an ECG. And we're going to look at the different parts of that as well. We're going to kind of bounce a little bit around as far as like looking at your score builders. And actually, if you have that, go ahead and leave that out. And that way I can tell you exactly where the information is at. I know it's in chapter 6. And let's see. So make for sure you review everything from 150 and 162 about like the cardiac cycle. All that information is free game. And even the pathologies, we will talk a little bit more with the pathologies on Wednesday. But today we're just going to talk about the ECG, and I'm trying to get to it. So they have a picture on page 374 in your score builders about like the Holter monitor of like with the ECG. An ECG and an EKG is the same exact thing. So if you see ECG or EKG is the same thing. And those are just electrodes placed, and you can see all those. We're going to look at each one of those. And then make sure you review all the medications, anything to do with cardiac and the angina scale. And let's see, where is it at? There they are. Okay. So if you go to page 384, they talk about a little bit more about the ECG. So there's a 12 lead. And there's 12 views of the heart. And they have the definitions there too for the waveforms and intervals for like P wave, PR interval. You should be able to see that on there. Oh, yours might be on a different page than mine, right? Yeah, so it's like you'll see the electrodes. I think we're like a page or two off with this book where I have the newer one. I think that's it. I think I see. Do you see the PR interval at the top? P wave?
Yeah.
Okay. Yeah, so what page is that? 380. Okay, so 380. And, there's different exercise stress testing too that we're going to look at. But so we're going to dive deep in between which one of these waveforms mean what, okay? And so I'm going to go on down. We'll come back to all the electrodes too. So when you have, this is different than when we're talking about circulation. This is the conduction system. So the heart has its own conduction system. You could even take the heart out of the body and it could still do the whole conduction system too. So it operates on its own for that. Okay. So the first of the pacemaker of the heart is going to be the SA node, and that's the sinoatrial node. So SA node is going to fire first, and then it's going to go to the AV node next. And we're going to talk about each one of these. And the bundle of His, the bundle branches, and then the Purkinje fibers. Now, the AV node is not going to send the message until the atria have emptied. Okay. So the atria will empty, and then the AV node will go ahead and begin the conduction. Then it'll begin the conduction. So during this time, I'm going to try to connect all these dots together when we talk about waveforms too. So the P wave, as you can see in your score builders, it's called atrial depolarization. So depolarization is when there is enough of a charge to where it's going to make the atria contract. Okay. So this is when they are going to contract. They're going to have the highest level of a surge, and then we'll talk about the next steps. But this P wave that you're going to see on, let me see where the slide is for that. This talks about the boxes. So just keep that in mind for a second. I'll show you here in just a second. Okay, what the P wave looks like. The first little hump. Yes, yeah. First little wave. So then when we get to the, I was just making for sure I could say for both of those. Yeah, okay. Then at the PR intervals, the next after the P wave, and as you can see by definition, it says time for the atrial to depolarize and conduct from the SA node to the AV node. Okay, so this is when the AV node will contract. All right. Or I shouldn't say contract, but send the message, I guess I should say. Send the message for the conduction system. This is when it travels from the SA to the AV node during that time. I'm going to go on down for just a second. And here's a good picture. Like on slide 7, this kind of shows you what we're talking about here and kind of mirror image, right? So we have the P wave, again, as atrial depolarization. And that is going to, when it's going to be the highest of the voltage for the atria to contract. And that is when you have when it gets to the AV node, okay? So you have the SA to the AV node, and then that's when it's going to contract because it has to make for sure all that blood gets pumped out into the ventricles, right? Then when we get into the QRS complex, this is when the ventricles are going to have the highest voltage, okay? And this is when they are going to be contracting. Now, this is when you go through, let me get my other notes out here too. So when you have this QRS depolarization, it's between 70 to 100 milliseconds. 70 to 100 milliseconds for that one. Okay. And it should be, as you can see, right through here through this QRS, it should be skinny. It should be narrow, right? And if it is not, if it's too wide, then that means that there's going to be an abnormally slow depolarization. If it's too wide, there's going to be some kind of ventricular rhythm then, more than likely, if it's wide. So during this, you would check if there was a wide QRS, there could be some different situations too. They could have a bundle branch block. So like where we talk about the bundle branches, they could have a block, and maybe that's why they're not depolarizing like they should. It might be because of hyperkalemia, or they might have a sodium channel block. So those three things, okay? So bundle branch block, hyperkalemia, or sodium channel block. And if that's the case, the leads that you're going to check are going to be V1 to V6. We'll look at each one of those, but V1 to V6. Okay. All right. We'll come back to the others. All right. So just remember, depolarization is contraction. Then when we talk about repolarization, it doesn't necessarily mean resting. That's when it's the decrease of voltage. So there's a step, right? So we have depolarization, the cells reach the highest voltage for contraction. Then when it gets into repolarization, this is when the voltage decreases. And then it can go to resting, relaxation after that. So don't get confused with thinking repolarization means resting. It just means a decrease in voltage, okay? Decrease in voltage. Okay. All right, so does that make sense so far? So we have P wave, atria, depolarization. Then we have the PR interval, which is the time for the atrial to depolarize and conduct from the SA to AB node. And you can see the seconds in there for the PR interval. That's like the communication between the two. And so like if you had a long PR interval, if like it looks so longer, that means it took longer for the SA to communicate with the AB node for the duration. So if you can see on this PR interval, the definition, it says normal duration is 0.12 to 0.20 seconds. 0.12 to 0.20 seconds for PR interval. So if the line looked longer from the P wave to the Q, then obviously it's taking longer for it to conduct. Okay, so it's longer for the message to be received for some reason. I'm trying to put it all together because I'm afraid if I talk about all the norm and then go back, it kind of becomes somewhat gets confusing too. All right. Okay, the next part for that one. And you can watch the videos too. Like I feel like the videos do a good job to show you like how the conduction actually works, to show you when does it fire. And I would break down each one of those videos and just take notes on them. I think would be the easiest part of just pausing it and taking notes, pausing it and taking notes to really understand for each one. Okay. And then, so we just talked about, so QRS is where the ventricles are depolarized. The cells have the highest voltage. And then when we get to the T wave, this is when the ventricular repolarizes. So the thing that's missing, that's not mentioned here, is when do the atria repolarize? They repolarize during the QRS, but it's not seen because there's a higher voltage for the ventricles to where you don't see where the atria are repolarizing. Does that make sense too? So make sure you make note of that because it's not shown, but it's good to know that the atria will have the lowest voltage during the QRS complex while the ventricles are contracting. And then the T wave, like I said, that's when the ventricles will repolarize and they'll have the lowest voltage. And then it starts all over again. Okay, the heart will start the conduction system all over again. Okay. Okay. So just to talk a bit more too, so the PR interval, right? This is when the atrial will depolarize. It's through the P wave, because the PR interval starts from here to here, beginning of the P wave and before the Q. Okay. So that's when the atrial depolarizing, and then the delay in AV junction. So that means where it's just that communication, like I said before. And that allows time for the atria to contract before the ventricles contract too. So, I mean, if you had this P wave really, like a really short PR interval, then it would be like they're on top of each other. It'd be like almost like the atria and the ventricles are contracting almost at the same time. So that's why there has to be a little time in between to allow enough for that blood to go through, and then the ventricles to go ahead and contract and push the blood out too. Okay. So that's why there's like a lag, so to speak. All right. So these are all the different pacemakers of the heart. The normal pacemaker of the heart should be the SA node. And that's how you're going to get this 60 to 100 beats per minute too. Now, if the SA node, if there's something that's going on, like there's an arrhythmia, there's an abnormal contraction going on, then it could be the AV node contracting instead and starting the rhythm instead of the SA node. So in that case, the rate is usually between 40 to 60 beats per minute. Okay, so it's like a backup pacemaker. Then you have also these ventricular cells that back up pacemaker with an intrinsic rate of 20 to 45. So it's like the other backup, right? So if this doesn't seem to want to contract normally, then this one would take over. And we're going to look at that, okay, and divide each one of those. All right, so any questions so far about just the waveform in general? Probably the one I did not mention yet was this ST segment. So let me go back up here to show you in between, because I didn't have it on here. So the ST, as how it says in your score builders, is an isoelectric period following QRS when the ventricles are depolarized, okay? So this is just, you can see from the S into the T. And this makes a big difference to know when we look at what would be abnormal. So when we are going to look at myocardial infarctions, you're going to have an elevated ST wave. Okay, it'll be elevated. It'll be a lot higher, and I'll show you what that looks like. But this is what it should look like normally. Now, let me see. Yeah, so there's a lot of differences, from what I read to and what I looked over. That's kind of, they look at this ST to look to see, is it elevated? Is it depressed? To see what would be the cause for it. So you're going to look, as long as you know this is what it should look like normally, then it'll make sense when we look at it abnormally here in a few minutes too. Let's see if there's anything else. So like how it says in your score builders, it's a period following the QRS when the ventricles are depolarized. They're depolarized. And I think I have that on the other thing too. So we'll look at each one. We'll come back to that too. All right. All righty. Okay. So we're going to kind of change gears just a little bit. So make sure you review the waveforms. The biggest thing to probably help you is watching those videos and just writing down the notes for each one and memorizing those waveforms of what happens when. So we're going to look at the ECG paper next. So when you're reading this, there's a couple of different ways you can calculate it. So one small box is going to be 0.04 seconds. The smallest box is 0.04. Then you're also going to have a big box to where you're going to have 5 small boxes. It's going to be 0.2 seconds or 0.20 seconds. So that you're really looking at the width, but it's important to know one large box vertically as well is going to be 0.5 millivolts, okay? But really what you really look at is the width, okay? And we'll look at each one of those. So if you go to the next slide here, now we are going to be looking at strips that are only 6 seconds long. Okay, so just keep that in mind when you're calculating it. We're only going to do the 6-second strips, so that way it's easier to calculate. And so each separation here is this is 3 seconds and this is 3 seconds. Okay, but a total of 6 seconds. So there's 15 large boxes in a 3 second. So that means there's 30 boxes overall for the large boxes. Okay. And it's not as hard as you think it is. So we're gonna go ahead and go to slide 14. And how you calculate beats per minute there's a couple different options, but this is the one that I think is the easiest. You're going to count the R waves. Okay. So there's an R, an R, an R, an R, an R. Okay. So if you count all those up, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9. Then you times that by 10, and that gives you 90 beats per minute. So if you look at those R waves and be able to calculate those on a 6-second strip, and all you have to do is multiply it by 10, and that gives you that 90 beats per minute. Follow me so far? Okay. Good deal. Let me go down. So if you go to this next one here too, there's a couple different ways you can kind of determine too. So you can also, obviously we're looking at this R wave. If, let me think about how I can explain that for just a second. Let's go to the next one. I think it's easier to look. Yeah. So if you look at this is like saying how many, it was how many seconds? Yeah. How many seconds, right? So if you had another one, it was like every 300 seconds and then 50. Hold on, let me think about that. Approximately one box less than 100 is 95. Oh, yeah, that's right. So you can start to see. So if you can look at this R wave and the next R wave, okay? It's not seconds, it's by beats per minute, sorry. See where this 100 is? They're saying they just are normally guessing to be 95 beats per minute because it's not 100 beats per minute because it's not exactly at the 100 mark. So the wider it is, so that makes sense, right? So if they were on top of each other, that would be like 300 beats per minute. Or if the next R wave was right here at this 150, that'd be 150 beats per minute. Or if it was exactly at the 100 mark, then that would be 100 beats per minute. Okay. So I would make for sure by calculation, one box, then that's going to make a difference to be 300. If it was 2 boxes over 150, 3 boxes over is going to be 100 beats per minute. 4 boxes over would be 75. And so on. So I think that's the easiest way just to say, okay, if it was 1 box from R to R, right? This R to R interval is what it's called. This R to R interval, 1 box over is going to be 300 beats per minute. 2 large boxes, 150. 3 is 100. 4 is 75. 5 is 60 beats per minute. And 6 is 50 beats per minute. So there's 2 different ways you can calculate it that way. Okay. Is that confusing? No? Good? All right. So now we're going to look at these R to R intervals and say, are they regular? Determine regularity. Looking at the distance between one R to the next. And you can use like a caliper, like where you can mark. Have you seen like those caliper things? They're like the little pointy things, and you can go from one to the next to see exactly, is it the same? Yeah, you could do that too. Yeah, same thing. And then some markings on a pen or paper, and then you can see, are they exact? So yes, in this situation, they are regular, right? They're not irregular. So the interpretation here is that the RR intervals are regular because there's no abnormalities. They're the same. Then when we look at the P waves, we're looking at all the P waves on the 6-second strip and saying, do they all look alike? Are they normal? Is there a P wave? And like, yes, there are P waves. There's not any missing, and they are normal. Okay, so there is one P wave for every QRS. So this would be considered a normal rhythm, a normal sinus rhythm right here, because there's no abnormalities. Now, when you're determining this PR interval, it's so hard to see these little teeny tiny boxes. You know, if there's a way for you to take this and zoom it up, I think it's a little bit easier just to take the strip. Let me see if I can make it any bigger and still be, oh no, it moved. Just kidding, you can't do that because I forgot that I marked it. So, yeah, you'd have to zoom the whole slide in. Yeah, there we go. So I'm going to zoom this up here. And normal is between 0.12 and 20 seconds. And the same thing should say, yeah, and it's the same definition in your score builders too for this PR interval. So what you're really doing is you're just adding up these little boxes. Okay, so a little box, do you remember what I said it was? A large box is 0.2. Small box is 0.04. Yeah, 0.04. So you're going to calculate all these little boxes. So let's see here. I wanted to make for sure that was correct on there. So if you did 0.04, and then you times that by how many boxes? So 1, 2, 3, 4. I think it was times 4. 4 times 5. Yeah. So if it was, the maximum would be 5 little boxes. So if you calculated, so like 3, right? This is the normal range it should be within, right? So if you did 3, go ahead and do 3 times, if you want to get your calculator out, so that way you can figure it out too. If you did 3 times 0.04, that'll give you 12. Okay, so 3 times 0.04, that's going to give you the beginning range. And then if you did 0.04 times 5, that's going to give you the 0.20 seconds. So that's where they'll be in between. So you would count these little boxes in between starting here. And that's a big thick line too, but you see 1, 2, 3, 4 is what I think I'm reading. 1, 2, 3, 4. It looks like 4 boxes to me, so it's within normal range. It's within this normal range. So if it was 4 boxes, right, that would be 16 seconds, 0.16 seconds. So on here, I know it's kind of hard, it says it's 0.12, so really it's 3 boxes, but it doesn't look like 3 boxes to me. It looks like more than that, right? So I'll make for sure it looks clear as a bell on the test too, but for you to be able to read and say, oh, is it 4 boxes? Is it 3, 4, or 5? It shouldn't be more than 3, 4, or 5 boxes. Okay. Beginning of the P wave. Yeah, so this is the PR. So you're calculating from the beginning of the P wave, right where this line is, and then where the R wave is. Yeah. Okay. So that's how you calculate for that one. Yeah. Are you okay with that one so far? Okay. All right. So now when we're talking about this QRS duration, it should be really narrow. Okay. It shouldn't be that much of a length in between. The normal range is 0.06 to 0.10 seconds. It's not very long. So if you think about it, again, what was this QRS? What happens during QRS?
It's not contracting much during the QRS, right?
So if you think about it, that R goes all the way up, right? It's high. Think about it that way. This is the highest peak of voltage. So the ventricles are bigger than the atria. So they're going to make a bigger wave. Okay, so the P wave, that's when the atria are contracting. Then the QRS is when the ventricles are contracting because it's such a larger wave compared to the P wave. And so during this time, it shouldn't take that long for all that blood to be pumped out of ventricles, okay? And then be able to circulate throughout the rest of the body. Does that make sense now?
Yeah.
Okay, so then during that QRS, the ventricles are depolarizing, and this is when the atria are repolarization, because you can't have them both high voltages at the same time, right? So the atria, they have the lowest voltage during the QRS, and then the ventricles have the highest during that peak too. All right, so if you look at these boxes, one box is going to be, let's see, hold on a second. Let me figure out how I can look at that. So I think it's easier when you look at the bottom, right in between here, and it almost looks like a one box to me, even though they're saying that it's 2, right? Let's see. So 0.0, yeah, 2 boxes. So 2 small boxes is going to be 0.08 because 1 small box is 0.04. So on here, they're calculating, I'm trying to zoom in it, is that this QRS is 2 boxes. And that's just such a thick line, but it is 2 boxes right through there for the whole range for that. Okay. 2 small boxes is how you would calculate that for this strip. But normal range, there should be no more than 3 boxes. Okay. It could be as narrow as 1, but no bigger than 3. And this range of 0.06 to 0.10 seconds. So like anything else, we have to know all the norms so that way you can identify what's going to be abnormal. Okay. So I'm going to go to slide 21. Any questions so far? No? Okay. All right. So if you go ahead and calculate the R's on here of how many R's there are, and then how do we get the beats per minute? Yes. Yep. Times 10, and that's going to give you the 90, right? Because there's 9 R waves on there. Then, so they're regular, right? The RR intervals are regular. They don't look abnormal. The PR interval on here is 0.12. It's the same strip as what we looked at earlier. So this is a PR, beginning of P wave to the R is 0.12. And then it's no different than what we just looked at. The QRS on this strip is 0.08. So this would be considered a normal sinus rhythm. So when you see NSR, that's what that means. It's just a normal sinus rhythm. Okay, so you're going to see that abbreviated NSR too. All right. So a normal sinus rhythm, the SA node is always going to be the one that the electrical pulse. Always the SA node, because that's what should normally happen. Now, if there is a other rhythms that do not conduct via the pathway are called arrhythmias. Okay, so if they don't go through this normal conduction cycle of using the SA first and doing the full all the way through exactly what we just described as what would be normal, then those would be considered arrhythmias. Okay, arrhythmias, not a normal rhythm. All right, so those are just the parameters. This is just saying all on one slide of what we already went over on 23. It's saying what's the rate 60 to 100, which we already know, right? Normal rate for beats per minute for heart rate is 60 to 100. And then just memorizing what these PR intervals should be and what the QRS should be too, okay, of those numbers. Let me look back at something for just a second. I thought it said... 1 box. So if it's 1 box, let me calculate that real quick. 0.04, that would be 1.04. It's 2. It's 0.8. It's 3. It's 0.12. Does that make sense on that one? Should be 1, 2. Yeah, that doesn't make sense. Hold on. Just a second. 0.04 times 3 is 12.04 times 5. Let me, they had a typo on this one. So it should be 0.04 because that would make sense. Yeah, because 1 box is 0.04 times 3 is 12. Sorry, go ahead and fix that slide. On QR restoration, it should be 0.04 to 0.12. Because this other one's correct. So that, where it says on this slide is correct, 0.04 to 0.12. Okay. So obviously any deviation from above is considered a sinus tachycardia, which is going to be more than 100 beats per minute, or a sinus bradycardia, which would be less than 60, or it's going to be an arrhythmia. Okay. All right, so these arrhythmia formations, we're going to look at each one of these, how these arrhythmias can arise from for the problems, okay? So if the SA node is firing too slow, then it's going to be a sinus bradycardia. Sinus bradycardia. If the SA node is firing too fast, it's going to be a sinus tachycardia. Right. Now, sinus tachycardia can be an appropriate response to stress, right? If you're stressing the heart, if you're doing exercise, or if there's something that's stressing the heart, the sinus tachycardia can be a normal if it's not at rest. Follow me so far? Okay.
So that would, okay.
Yeah.
It would be like closer together. If it was a.
So if trying to say what the waveform is going to look like.
It would be faster.
Yeah. So if you think about like an electrical circuit, right, and like how quick it's going to send that pulse, that waveform, then if it's just slower than normal, right, it's just not as speedy, then it's not going to have as quick of a response, right? And then the same thing, if it's too fast of a response, then it's going to make a bigger difference with that too. So when we're looking at this, what you're really going to be looking at is how is it changing the P wave, right? What is it doing to the atria, to where the rhythm, the wave is going to look different. And there's a video on there too that does a really good job of explaining from one. It has like these little humps in the P wave to show you both atria of what's happening at the same time. So you can watch that video to show. It'll say, oh, if it was slower, or if it was less. Okay. So for the if it was a slow, then the P wave is going to almost look not as narrow, right? It's going to look wider, right? And then if it was fast, the P wave is going to look skinnier because the seconds, there's less seconds too. Does that make sense on that? Okay. All right. Then we have all these atrial cell problems, okay? So if you have, I'm trying to figure out how I can describe these PACs. The PACs, a premature atrial contraction, they just fire occasionally. It's like they're not contracting normally like how they should. It's almost like they have a lag, okay, where it's not continuous of firing. Then if they are continually firing, I'll show you what it looks like on this loop in the next picture. Then if they're firing continuously, these atrial cells, then you're going to have an atrial flutter. So if you look at this right through here, So you have what's called a re-entrant pathway occurs when an impulse loops and results in a self-perpetuating impulse formation. So this is when I was trying to figure out how I can explain it the best way of what this looping, this re-entrant circuit, it's like the information is looping. It's like all these little cells are not communicating well within the heart. Okay. And it's like it's confused almost, of like the cells are making it confused to not have a normal electrical pathway. Okay. Let me see if I wanted to add anything to that too on that one. Let's see. Where is it at? Okay. What happened? I'm gonna get rid of this book for just a second. I'll go through. Hold on, I need a bigger desk. Let me get rid of this for just a second. Those are PVCs. Oh yeah, there it's on the next page. Okay. Yeah, so just remember, like if it looks like it's looping, right? If you see a picture like this where it shows like as if it's looping, this is going to be more considered of a flutter. Okay, so by definition, make sure you know that when it's an atrial flutter, it's like a fire continuously due to a looping recurrent circuit, and it's happening within the atria. And then by definition for PAC is like the atria cells are firing occasionally from a focus. It's like they're the opposite, okay? These two right here are the opposite from one another. All right. Now, if by definition, if the atria cells are fired continuously from multiple foci, or fired continuously due to multiple micro recurrent wavelets, they call it, then it's considered an atrial fibrillation. Either one is considered atrial fibrillation from these. So if you look at right here, this is like as if this is the atrial tissue. You have like these wavelets that are occurring. They're wandering from small areas of activation. They're like chaotic, okay, colliding with one another. It's like as if this impulse, the electrical wave, it's like they didn't understand the information or something's misleading. Okay, so all these cells are just not communicating in the atria correctly, is what's happening. Okay, from that one. There's all these definitions of what they mean. So it's kind of just memorizing it, you know, what is happening in each one. So like an AV junction. Now, remember when we talk about like an AV node, right? We're talking about the AV junction here. So fire continuously due to a looping reentrant circuit, or there might be a block impulse from the SA node, okay? And that's how you can get these paroxysmal supraventricular tachycardia or an AV junctional block. Now, the AV junctional block, you know, it's like as if the SA node, there's a block in between. Where's our circuit at? Let me go back up where it shows the heart and the circuit. Yeah, so like if there is a right here where the AV node is, like where it goes down, where's all of our fun stuff? Yeah, this is what I wanted. So how it goes from the SA node to the AV node, and then it goes down the bundle of His and bundle branches. So if there is a block to where the SA node is just not communicating to the AV node correctly, okay? Or there's a delay, or there's something that's happening to where the AV node, or there's a block somewhere to where it's not going to communicate correctly. And a lot of times too, it has, you know, especially if there's damage to the heart, or if there's something, you know, we'll talk about that in just a second, like as far as muscle and that type of thing. But just know by definition right now of what that means. Let me go back down. So just remember, atrial cell problems is going to be a PAC. And we're going to look at the waveforms here in just a second, okay? Atrial flutter, continuously looping. I think it makes more sense when you actually see it. All right, let's go down. Then it's the same thing except for a ventricular fire occasionally. So if you see this terms occasionally, they're firing occasionally. It's no different than a PAC than it is for PVC. It's just where's it at? Okay, PVC is the ventricular cell problems now. And then the fire continuously is going to be a ventricular fibrillation. And then fire continuously due to a looping recurrent circuit is ventricular tachycardia. So just memorizing these terms, okay? All right. So let's go ahead and tell me again, how would you calculate this one right here? Well, just the beats per minute. Let's just say beats per minute. Yeah, sorry. Yeah. So what would this be, you think? What would be the beats per minute, you think? How many R's are there? 3. And then what would you? Yes. Yeah. So that would be 30 beats per minute. Is how you. So this makes sense because it's less than 60 beats per minute to be a sinus bradycardia. Okay. For that one, I think it says it on the next. So the etiology behind it is that the SA node is depolarizing slower than normal. That's what we already talked about, right? So a couple different things, for that to not make it too confusing. Like when you're talking about sinus bradycardia, you're looking at how long of a duration is it from one to the other, right? How long is it taking for that impulse to occur? And this is when the SA node is just not, it's going at a slower rate than normal for depolarization. It's still working. It's just taking longer to do so. Okay, longer to do so. All right, so this one, there's a lot of R's, right? So you would calculate, you would say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. And then you times that by 10 is going to get you this 130 beats per minute. Now, do the R waves look regular? Like, are they in between the same amount? Yes. Okay, so they would be regular. Are there P waves? They all look to be the same, even though they're all squished together. They're considered normal. The PR interval here would be 0.16 seconds, and the QRS duration is, if you counted all the little boxes, would be 0.08. And this is what's going to give you that sinus tachycardia. Okay. So that's how it's going to look like. So let's say if you have a patient in the ICU and they're hooked up to this heart monitor, and there's going to be a monitor right there in the room, and you're going to be able to see all these waveforms and what they look like. So if all of a sudden you're doing exercises and then all of a sudden the heart rate is showing to go up, and then you can start to look at, do these R waves look the same? Are they continuous? Oh, it looks like they're in this sinus tachycardia, right? Especially if they're just laying there resting, okay? Then that's going to give you a better insight, like, what's actually going on here? Or if, you take their heart rate and then you look up here too, and it looks like the QRS, the whole complex just looks a lot slower because the SA node is not firing like it should. It's just a slower to do so. Does that make sense too? Why that's important? Okay. So rate of more than 100 beats per minute. So this is a deviation from a normal sinus rhythm. Okay, so normal sinus rhythm is what everybody wants to be. But this isn't really what we're looking at, like when it's at resting. Okay. So the SA node is depolarizing faster than normal, and the impulse is conducted normally, though. It's still the normal, right? There's still a P wave. There's still a QRS. There's still a T wave, okay? That is considered normal for that. So a lot of times, too, it could be physical or psychological stress that could be considered not a primary arrhythmia, right? Like I said, if you start to exercise or if you stress the heart, then you're going to have more beats per minute. and that's not going to be considered abnormal. But if it's arresting and this is what they look like, then this is what they'd be diagnosed as a sinus tachycardia. Does that make sense on the difference for those? Okay. All right. Something doesn't make sense, let me know. All right, now like what I said, by definition, we're going to look at what a PAC looks like and a PVC next. So for these premature atrial contractions too, this is when, see how this P wave just does not look normal here where these arrows are? You can zoom in. They don't look regular, right? And then then it's regular, and then you have another one too. So when you see this, exactly like how this P wave looks, this is when, by definition, where'd you go? It's up here somewhere. They fire occasionally from a focus, okay? They're firing occasionally. It's like they're not firing correctly for that one, okay? So if you saw this strip on a test, what you're really going to have to look for is what does that P wave look like? Does it look abnormal for those? Okay. So what it is saying it's occasionally irregular, right? So the R waves, they're not consistent with them in between, are they? There's not, like, especially look at this lag in between of this R to R compared to this R to R. It's occasionally irregular, and sometimes it's regular. Like right here looks regular to this one looks regular. Does that make sense for those two? And then it's saying for the P waves, 2 out of the 7 are different. So this wave and this wave out of the 7 are irregular. They don't look the same. Now this PR interval, if you were to calculate it from P, like for this one, not looking at that one, but like from the P wave to the R, you would calculate those small boxes of 0.04 and you would multiply that to get 0.14 seconds. And I'm trying to see, they're really hard to tell. So 0.04 times, it should be 4. No, it would be 3 boxes, right? Like that must be in a half of a box, this one. Yeah, so it's really hard to see, but for the PR, it looks more than that. 1, 2, 3, 4, 5. To me, it looks like 5. 1, 2, 3. I feel like I need a magnifying glass. To me, it looks like 4. P wave, like if I'm looking at this one right here. 1, 2, 3, 4. Well, 5. This is where the peak is here. And it's still within normal though. Okay. Then same thing for this QRS duration. It does look like 8 to me, 0.08 lived 2 boxes. So it's saying it's still a normal sinus rhythm, but they have premature atrial contractions because you still have a P wave, you still have a QRS, and you have a T wave still, okay? So they consider it an NSR with a premature, or PACs. You'll see NSR with PAC with it, okay? Premature atrial contraction. Follow me so far? Okay, let's go to the next one. So talking about what does that mean? So these ectopic beats is what we're considering. They're abnormal. And they originate in the atria, but not in the SA node, okay? Therefore, the contour, the P wave, the PR interval, and the timing are different than a normal generated pulse from the SA node, okay? So, so where do you think they could possibly originate from then? If these ectopic beats, just these two right here, are not starting at the SA node, where could they be starting from instead? What do we see? Yeah, it could be the AV node, right? So that one was, and just remember so the SA node is going to be 60 to 100 beats per minute. And then what about the AV node? Yeah. You're getting it. I was just trying to repeat that way it sinks in. Okay. Yeah. So that's going to be probably where that's circulating is from that AB node instead of the SA. Okay. All right. Yeah, so it's saying that right now too. So atrial cell forms and all pulses then conducted normally through the AV node and ventricles. So it's just saying what's happening for that one. Okay. Yeah, it's pretty much saying the same thing. All right, so now let's look at this one, right? So you have how many beats per minute? We have, let's see, 6, right? 1, 2, 3, 4, 5, 6, because you can't calculate this one right here. There is no R wave, okay? So this is we're gonna start looking at what looks more abnormal, right? So for me and how I always remember, I see how this is inverted. This R wave is inverted. Then I think it looks like a big V, right? So then I'm like, oh, this is a PVC then because it looks like a big V upside, for that one. That's how I kind of memorize what the PVC looks like. So, but you still calculate just the R waves because that's all that's there. So it's still going to be considered a 60 beat per minute. We're not even looking at this R wave. There isn't one. So regularity of R, it says occasionally irregular because of right here. This is not regular. From this last one to this one, it's not regular, okay? So P waves, there is none for the 7th. So I just see a T wave. I do not see a P wave here. There's no P wave for the 7th one right here. All the other ones are for the PR interval is 0.14 seconds, except there's nothing to calculate here. You can't calculate a PR wave on the 7th one. QRS duration, all the other ones are 0.08, but the 7th one is really wide. That QRS, and plus it's irregular. Okay, so when you see this one, this would be considered a sinus rhythm with one PVC because there's only one. If you saw another one on here, then it would be a sinus rhythm with 2 PVCs is how that would be deemed. Does that make sense on that one? So when you go by definition, again, so premature ventricular contractions fire occasionally from one or more foci, okay? That would be the definition for that one. They're firing occasionally for the ventricles too. And if it helps you, I probably would look at some more videos like on YouTube. You can type in PVCs if that would be more helpful. All right, where am I at? All right. So let's talk about that one. So there's an ectopic beat that originates in the ventricles, resulting in a wide and bizarre QRS complex. When there are more than one premature beats and look alike, they are called uniform. When they look different, they are called multiform. So let's say if you had 2 of these PVCs, you would see, do they look the same? Are they uniform? Or do they look completely different from one another? Then you would consider that a multiform instead. So this is when one or more of the ventricular cells are depolarizing and the impulses are abnormally conducting through the ventricles. So what's happening, again, you got to remember, is just we're talking about cells at this point, right? All these little cells that are supposed to be communicating with one another in the ventricles there's more than one that's trying to depolarize at the same time. Like the impulses are abnormal. They're not on the same page, okay? I guess the best way I kind of think about it too, like when you're on a team, right? Or if you had to care for a patient and you have multiple people having an opinion and you're like, oh no, my opinion's this. And someone's like, no, my opinion's that. That's what I think about with PVCs or with PACs, because it's like multiple things are happening at the same time. If everyone was on the same page, like if all these cells are on the same page, we would have a normal conduction. Okay. If that helps you. So when you're talking about the only difference between a PAC and PVC is what cells are they. If If it's PAC, that's atrial cells. As if it's a PVC, it's the ventricular cells. That's the only difference. All right. Yeah, so this is when like an impulse originates in a ventricle, conduction through the ventricles will be insufficient, the QRS is going to be wide and bizarre. Let's go to the next one. Okay, we're going to look at each one of these. All right, so now this is what atrial fibrillation is going to look like. I went on down to slide 49. So this is going to be 100 beats per minute. So you would calculate that by 10. They are not irregular. So they would be considered, the RR intervals are irregular. There are no P waves because they just look like little scribbles. Okay, little scribbles. There is no PR interval because it just looks like little scribbles in between each one. It's not consistent between. You could still calculate this QRS, like saying QRS would be 0.06. This is what AFib would look like. Okay, AFib. Let me go down. All right, so what's happening, right? There's no organized atrial depolarization. So there's no normal P wave. Impulses are not originating from the sinus node. The atrial activity is chaotic. So if you see by definition, if it says atrial activity is chaotic, that's what's going to be your atrial fibrillation. So make sure you highlight that chaotic or atrial activity is chaotic. This results in irregularity, irregular rate. And so for AFib, it affects 2 to 4%, up to 5 to 10% if they're 80 years old or older, too. Happens in 5 to 10% of people for AFib. So if you're in a ICU and you see, I'm like, oh, I don't see a P wave, and the QRS looks fine, then I'm thinking probably more AFib, too. And that's when the SA node, there's not a firing, the atria are not depolarizing. So what's happening then? What do you think is happening in the heart at the moment with the blood and everything else? What's happening, you think?
Pushing it through like it should.
Yeah, so it's not pushing it through like it should, but at least it's still getting through the ventricles, right? It's just not coming from the SA node. Maybe it's coming from the AV node. Maybe it's coming from the, which the other one I don't hear as much, to be honest. What was that other node earlier? The ventricular cells, too. Backup pacemaker. So maybe this is just the ventricular cells working instead for 20 to 45 to help with that beat. But more than likely, it's going to be the AV node, too. Okay, so these are the backup pacemakers. Just remember that. So the SA node is not firing correctly. So it's one of these that's working instead.
Is that why, this may be like totally wrong.
No.
Is that why, like if that's happening and it's not working properly, is that why the bottom part maybe get bigger with age? Remember last?
Oh, like muscular hypertrophy?
Yeah.
No.
Working harder?
Not
really.
No, we'll talk about that here in a minute. Yeah, keep that thought in mind. Keep that thought in mind. I don't want to say no, but there's other reasons too. Yeah. Good questions though. I lost track where I was. What slide I was on. Okay. So they said recent theories that say that there's these reentrant wavelets conducted between the right and left atria too. So like those wavelets that was shown in that one picture, like there's like all these wavelets that are occurring in between the atria. And impulses are formed in a totally unpredictable fashion, and the AV node allows some of the impulses to pass through. So it still will have a contraction for the ventricles to depolarize, but the atria are just not depolarizing like they should, okay? Because of all of this communication between right and left of the impulses. Does that make sense? Okay, sure? It's a lot. I know it was going to be a lot. All right, now we're going to look at when you have to, so the biggest thing too, just to remember is memorizing these slides, these pictures, And like, what is what, right? When you don't see the P wave, it's going to be an atrial fibrillation. When this looks like sawtooth, like they're sharp P's, they call it a saw or a flutter wave or a sawtooth wave. That's going to be a flutter. So if you just start to remember, like, oh, the P waves are not correct, so that's atria. And then the flutter, I don't care if you want to think about a butterfly and they have whatever you want to think about, right? Or these flutter waves, maybe like an ocean and they're really deep. I don't know. I'm goofy and I do different things to memorize things. I try to tie it in with something in the real world so I can memorize it. Yeah. Yeah, that'd be good. That would be good.
I remember now I have those.
Yes. Yeah. So as soon as you see those high peaks and they look like mountains and they don't look like hills, then that's going to be more of a atrial flutter, okay, for the P wave. So they have this sawtooth pattern, right? So this is when they're formed at a rate of 250 to 350 beats per minute, just based upon the P waves, because there's no P waves. Hold on a second. They just have, instead they have flutter waves, okay? Only some impulses conduct through the AV node, usually every other impulse. What does it say? So if you notice, there's a lot of these waves before finally the AV node gets a hold of it and able to push it through the ventricles. Does that make sense? Yeah. So finally, there's others are blocked in the AV node as the node repolarizes. So every once in a while, the AV node will pick it up so that way it can have the ventricles to contract. So they're saying no P waves, however you want to describe that, instead you just have these flutter waves instead. It's not a normal rhythm. Okay. The next one on here, we're going to look at, it's called paroxysmal supraventricular tachycardia. So if you notice, these R's are, I don't know why it says regular. Really, it's irregular because you have regular here and regular here, regular here. But then, yeah, you do have regular between the smaller waves. But all in all, they're not consistent. Then for this PR interval, it says you either have 0.16 seconds or you have none. Like down here, you probably have none. You don't have any for that one. So this is when the heart rate suddenly speeds up, often triggered by a PAC, but it's not seen here, okay? And the P waves are lost. So a lot of this, if you can see, don't get confused between the T wave and the P wave, right? So I'm like, oh wait, is that a T wave? Yeah, that's a T wave. And I'm like, well, where's the P wave? I don't see a P wave, okay? So that's when the heart rate suddenly speeds up and it's triggered by a PAC. Remember what we talked about, the atrial cells, the PAC, they're not conducting correctly. Okay, that's when you're going to have that circuit looping. So you can go back through for each one of those. All right, let's look at this ventricular tachycardia. Looks nuts, right? Looks crazy. There's no consistency here. What is the rate? So you could still calculate these rates, which is really hard. It'd be easier just to do it from the bottom and then be able to calculate this 160 beats per minute instead of the top. But I don't understand why it says regular because it's not really regular. P waves, there are none. There is no PR. They're still considering this a QRS duration even though it's upside down. And this would be considered ventricular tachycardia. Let me go through this one. Oh, wait. That's the R wave. Hold on a second. I always have to think about this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. I'm like, is that right? 16 times 10. Yeah. So you would do the peaks at the top here. And the humps. So this is like the QRS is what I was saying. It's wide. It's wide. Very wide. Very hard to tell of what is what here. It's more than 12 seconds for sure. And there are no P waves. It's just like you have just QRS and that's it. Over and over again.
Where it's not connected to the right, does that happen, or is that just?
Like this
Is that
thing,
just a misprint? Like,
I think that's just a misprint.
Okay.
That just looks like a misprint to me. Yeah. So there's looping in the ventricles is the most common cause. Ventricular tachycardia can sometimes generate enough cardiac output to produce a pulse. At other times, no pulse can be felt. Let's see if there was, yeah. Okay, so that's what ventricular tachycardia, which is, a severe situation, right, to be in. But ventricular fibrillation is worse, okay? On the next slide, this rhythm number 9. So as you can see here, they're wide, the QRS is, but they're not recognizable at all. This would be VFib for this one. Completely abnormal from the deviation. So this is when the ventricular cells are excitable and are depolarizing randomly. So this rapid drop in cardiac output, because there's not enough output, there's not enough ejection of everything, then death can occur if it's not quickly reversed. So if you see someone, hooked up to a monitor and this is what they're looking like, I'd be like checking all my electrodes, make sure they're sticking on correctly, make sure they're in place correctly to figure out, are they really going through VFib or not? Obviously, the monitor is going to go off saying it's an abnormal rhythm. Nursing should be picking it up too. But what if you're not in the ICU, right? Unless they have a Holter monitor on, a lot of times even in the acute care setting, if they're not, they might still have that monitor put in their pocket, and then it's being sent up to the nurse's station. But you don't have a monitor in the patient's room, okay? That's the biggest thing I feel like with differences between ICU and an acute is in the ICU, you get to see the monitor, okay? But in an acute, room, you're not. All right. So just make sure you just memorize the strips like this of abnormals and what they are, okay? And then just by definition. So I'm just going to take information straight from the slide and from the score builders, what I talked about, for the waveforms for that too, okay? All right, so we're going to go to the other one that's connected to this. Don't save. And let's see. Oh, come on. This ECG part 2 is we're going to look at next. I'm going to try to get through most of this. It's not as long as the other one, I don't think. I might be wrong. No, I don't think there's as many slides. Let's see how many. Yeah, there's a lot. So we'll try to get through most of it, and then whatever we don't get through today, we'll go through on Wednesday. Okay. Just take a little bit more time, and let me make for sure that I am sharing this. Stop sharing. Share. Window. Just say this one, I guess. Sorry, I'm trying to operate this at the same time and try to. Share. Working now. Hopefully. Okay. So now we're going to be trying to diagnose an MI and what that looks like. To diagnose an MI, you need to go beyond looking at a rhythm strip to obtain a 12 lead ECG. So this is when it gets a little bit more in depth. So if you see, if you zoom this in, you're going to see the leads of what they're called. Okay. So you have a 1, a 2, a 3. Then you have this AVR, this V1, this V4. So depending on the electrode, and I shouldn't have cancel it out on that. Let me see if I go back to. We'll look at the leads some more too at the bottom, but just making you sure that you know you're going to have 1, 2, and 3 leads, and you're trying to pick up where is this being picked up at. Okay, you're going to look. So the heart, or the ECG, the 12 leads, it looks at the heart from 12 different views. Okay, this helps determine what is happening at the heart, like where is the damage being done with a myocardial. Is it an anterior, is it lateral, is it posterior? So with the leads, it kind of helps you with that imaging to tell you where's the damage being done to the heart. Okay, and here are the 12 leads. So you have 3 limb leads, limb 1, limb 2, and lead 3. Then you have what are called augmented ones, the AVR, the AVL, the AVF, and then you have 6 precordial leads right through here too, okay? And so some leads will look at the anterior, the lateral, and the inferior portion, or even the posterior. So when we're looking at the waveforms, to really diagnose an MI, we are looking for an elevated ST segment. So this is normal right now, but we're going to look to see where with an ST segment and how is it elevated. So right here, let's pull this up. So if you can see all these ones that are circled, the ST segment is greater than 1 small box and 2 leads to consistent with a myocardial infarction. Okay, that's how they would diagnose that. In 2 different leads, you can see that it's more than 1. So see how it's raised, this ST, that's raised. That one's even raised, even though it looks abnormal, raised, raised. So it looks a little bit different from each lead. This is like as if you're cutting through, and you can see this is how the V1 through V4, how it's looking at the different sections of the heart. So from V1 to V6, it shows you what the view is of what those leads are looking at, okay? If you see changes in leads 1 to 4, they are consistent with a myocardial infarction. And then you can also conclude, because right here, this V1 to V4, it's looking at all just the anterior portions of the heart, right? So if there is an abnormal rhythm stated on this V1 through V4, and these are all V, so this is V1, this is V2, this is V3, V4, V5, V6. So by looking at these leads, on V2 there was 1, on V3 there was 1 on this lead, on V4 there was 1, V5, and V6. So they're all picking it up to say that there is damage, a myocardial infarction. You follow me so far? Or is it really confusing?
I get what you're saying, but they all look like they're higher.
And there should.
Okay.
Because you're looking to say, so for instance.
It's like okay, those leads picked that up.
Yes.
Okay.
Yes. So if let's just say you only saw an ST elevation on V2, but all the other leads looked fine, then you're like, is there something wrong with the electrode? Or is there something wrong? Or is that the only one picking it up? Okay. So you should see consistently with the other leads of the same elevation to save the anterior portion of the heart. Okay. So it's like they're all picking up the same picture too. Just a different. Okay. All right. So for this one, I want you to look at it, and I want you to see what leads do you think this person is having a myocardial infarction? Like where at? Yes, anterior portion, right? So on this next slide, like, yes, this person is having acute anterior wall myocardial infarction. And looking at, this one's the same as that one, looking at to say that the ST is elevated. It is elevated, especially at this B1 and B2 for a fact. So that's what an anterior wall myocardial infarction is going to look like. Okay, so make for sure, I think it's easier when you're looking at this one, right? To really say, oh, okay, yeah, this person's definitely having an anterior wall because it's all the V1 through V6, especially if you see changes in all the leads of V1 to V4 that are consistent with the MI, you conclude that they did for a fact have an anterior wall MI. Does that make sense to you? Because if you only had it on one lead, you're like, oh, can I really conclude that it's an anterior wall? But if they all are taking the same picture, so to speak, of that waveform, all those leads, you're like, okay, they must be having an MI at the anterior wall.
Look at just now, it doesn't show it on the fourth one, so it's
not
super accurate to go on.
Yeah.
Okay.
Yes. Yeah, like this one, you can definitely conclude that they've had an anterior wall for a fact. You can definitely conclude that, right? But this one, I'm like, oh, hold on, like what's really going on? And we're just looking at just the anterior, right?
Yeah.
All these others are different sections, but right now we're just looking at this V1 to V6. And I'm like, I really just see V1 and V2. V3 is not elevated enough, to be, and neither is V4, V5, or V6. Does that make sense?
So it could just be electrodes and stuff,
Possibly, or maybe there needs to be more testing to be completed to say if they actually have an MI or not. Okay. All right. But I mean, they can still deem it, obviously if you've had 4 or maybe every V1 through V6 and they all have an elevation, you're like, oh yeah, for a fact. But they say if they've had more than one on another lead, they could still say it's an acute MI. It's just not as consistent as if they were at all the other ones. Does that make sense on that one? All right. So that's all the anterior wall infarction and where that would be. All right. Now, the other portion, so we just said the anterior portion. Now we'll be looking at the other portions of the lateral and the inferior. So we'll go through some of these. And just remember, you have the 12 leads. Just make sure you look over those of what that means, of where from one to the other. I think the V1 and V6 is really easy to know. So we're going to look at each one. So you have limb leads and augmented leads that we're going to look at next. So obviously with the anterior MI, you're going to be using the V1 through V4. For a lateral MI, these are the ones you're going to be looking at what's circled. Okay, lead 1, limb lead 1, augmented AVL, and then V5 and V6, which makes sense because it's the most lateral portion of the heart that's picking up the picture. Okay, so just think the side of the heart. These are going to be the limb lead, this limb lead, that augmented lead, and then the back portion of the leads is V5 and V6. Follow me so far? Because it all just showing the lateral view. Then for an inferior view, which makes sense, it's just looking at the bottom portion. So the 2, the 3, and this AVF are the only ones that they're using to look at the inferior portion. Now putting it all together, okay? So let's look at this one, right? For an inferior wall MI, they're going to look different. So leads 2, 3, and an AVF. Okay. 2, 3, and an AVF. Right through here. So I think it's really hard to tell on this too, to be honest, that they are considering that to be an ST elevation. I'm like, how? But okay. They just don't look as significant, right? Let me look. If you have an anterior lateral, this is when you're looking like, do they have an anterior, both anterior and a lateral damage of an MI? Then you would be adding those all together, okay? So like, again, this V1 through V6, or let's just say V1 to V4, right? V1 looks fine. It's not that elevated, but V2 is, V3, V4. And the lateral portion is V5 and V6 as well, right? So they could be having this elevated. I think it's just really hard, and you just have to know they don't look normal, right? It does not look a normal QRS complex whatsoever for these two to be a lateral portion. So it's really just looking at each one of these waveforms and just memorizing which ones it looks like a lateral, because they look a little bit different. Okay. We'll get through this and then we'll be done for now. So when we talk about changes for an ST elevation, and then they can also have an ST depression too. So, but when a myocardial blood supply is abruptly reduced or cut off to a region of the heart, a sequence of injuries occur, which would be ischemia, right? And if it's not stopped, then it's going to go to necrosis, which would be an infarction, and then you're going to eventually have some scarring, right? So someone could be in the middle of an MI, or maybe they've already had some changes and they've had ischemia before they have had a heart attack, right? So maybe they've already had some kind of inadequate tissue perfusion, and then now they led into more of an MI and it was not stopped, therefore you have infarction. So you're always going to have an ischemia before you have an infarction, always. All right, so the ECG will change over time with each of these events. So if you look at this next slide here, and let's see. So this one, if you zoomed it up, this is what that ST elevation looks like, right? We already looked over that one. This ST right here is elevated. But on this next one, it's depressed, right? The ST is depressed on this one compared to this one. It's lower than normal, lower than normal. All right. Trying to decide if I want to go through that or not. Yeah, I think this is a pretty good stopping point. I don't know if I really want to. Well, yeah, let's go through this one real quick. Okay. All right, so let's just talk about like with the ECG changes in ST elevation. So before an injury, it's going to look normal. Ischemia, the ST is going to look depressed, or there's going to be a peaked T wave and then T wave inverted. So it almost does the opposite, right? So when you're looking at this on an ECG, like before they start to have any kind of ischemia, it's going to look normal. And to show the changes of the ischemia, it's going to look like this right here. See how that's a peaked T wave and then the ST is lower? So it's more depressed. This is ischemia. Okay. And then once the damage has been done, this is what it looks like. It goes to this ST elevation, does the opposite. So it's going to the ST be depressed first, and then all of a sudden it goes elevated too, if it's an infarction. So just know this is ischemia and that one's an infarction between the two. All right. Then for fibrosis, the ST segment T waves return to normal for that one. But the Q waves are still present, or they persist. So we'll look at these, okay? So A is shown normal. B, hold on a second, where's E? ST depression. Doesn't look like it. Oh yeah. So this doesn't really show really good depression on there, but it has an elevated T wave, peaked T wave on that one. And then infarction is going to look like this. A D is an ongoing infarction. And then you're going to get into these, an inverted T wave is an ongoing. And then you have this F, which is months later. And you're going to have, but the ST segment is going to look back to normal. too. So this is after they've gone through infarction, months later, persistent Q waves, but normal ST segment and T waves. So it almost looks like a normal sinus rhythm again, doesn't it? All right. I think that's good there. So that'll help me remember. We're on slide 30. We're stopping at slide 30. Okay. Any questions so far? Did I lose you at any point? No? Okay. Good deal. But yeah, let me know if you have any questions or even over the videos too. A lot of that won't be too bad. Some of that's review and medications. Yeah, that won't take too long then. Good deal. And stopping and end straight.